MS Plus acknowledges the traditional custodians of the land this podcast is recorded on, the Wurundjeri people of the Kulin Nation. We pay our respects to their elders past and present.
Hi, and welcome to the MS Plus podcast series. So today I'm speaking with Susan Agland, who's been an MS nurse from Newcastle, New South Wales for 21 years in probably the biggest regional MS centre in Australia. Her current position is neuroimmunology transitional nurse practitioner, which is a lot of words for studying to become a nurse practitioner in MS and other diseases that involve the brain and immune system. And so before we get into this discussion, I want to acknowledge that throughout this conversation, we will refer to women with MS. And by that, what I mean is people who are assigned female sex at birth. But we do acknowledge that not all people who experience pregnancy will identify as women. So Susan has a personal interest in stress management and fertility in MS, and she's also currently the co-lead in a study called Artificial Reproductive Technologies in MS that is looking both back at how fertility issues were experienced by women with MS and then forward to learn more about the current experience of subfertility and infertility. So thank you for speaking with me today, Susan.
Thanks, Jess. Thanks for having me.
So, does having MS affect fertility?
Strictly, no, it doesn't. But what we see in this generation is people are delaying having babies. The average age is gone up by another 12 months just in the last few years. And so delaying pregnancy does definitely affect a woman's fertility. MS itself doesn't, though.
And is it a common question that you hear through the clinic?
Yeah, it is. Pregnancy in general is a common question, and I'm glad that they're coming up because we should be having these conversations from very early in and assisting a person to know their personal risk about their MS and their chances to conceive.
And so, when we talk about fertility, you obviously hear a lot of other various terms. So, things like infertility and subfertility. So, what do they actually mean?
Yeah. So sometimes they're terms that are used interchangeably, but really infertility is the medical term for someone who has not fallen pregnant over 12 months of trying to. It's very medicalized, where subfertility is less identified like that, and it includes more cultural aspects of fertility issues. So subfertility is the difficulty becoming pregnant, and it is a more inclusive term, and we tend to use that more often nowadays. And it does seem to include, in the literature especially, the people who might be having fertility issues not because of a structural or an environmental reason, but a social reason. So you might have a same-sex couple or a single person wanting to have a baby. They are subfertile in that they have to think about fertility in a different way.
Absolutely. And that's becoming a lot more common. Women choosing to have children by themselves or people choosing to have children, as a single person.
Absolutely, yeah.
Yeah. Are there any sort of risk factors for having fertility problems?
Yeah, there's loads of risk factors. I tend to break them down into structural and environmental. So those structural things are your personal body's risks, things like endometriosis, having fibroids, ovulation irregularities. And then those environmental things are things that you have more control over, that you can modify, and that will increase your chances of becoming pregnant. So things like your amount of alcohol that you might drink, smoking, your weight, and stress affects your fertility chances as well. An environmental factor that you can't actually change actually is your age. So increasing age above the age of 35 means it's more difficult to get pregnant in the traditional way.
I think it's a bit of a kicker that stress is both a risk factor for fertility problems, but having fertility problems is also incredibly stressful for people.
Absolutely. It's a terrible cycle, isn't it? And the longer you're trying to fall pregnant and you can't, the greater your stress is, and it's just dreadful. Yeah.
Absolutely. And I know, like, from talking with women with MS who are going through pregnancy and things like that, and I've been having some conversations with women who also had difficulty conceiving with MS, talking about the stress. But another thing that came up quite frequently is medications. And so, a lot of people with MS obviously on disease modifying therapies to manage their MS. Should they stop MS treatment to start fertility treatment? What's the current thinking there?
Just many years ago, we used to say that. And lots of people would want to do that. And we find fewer people want to do that nowadays. More people want to do both things. They want to keep their MS well managed, but give themselves the best chance of getting pregnant and not causing any harm to that growing baby. So the recommendations, and I should preface this conversation by saying you're an individual, your care is individualized, and you should have a conversation with your neurologist, your MS nurse, your GP, even include your pharmacist because they're really knowledgeable on medication interactions and medications in general. But we're saying nowadays that potentially, no, not stopping treatment. Depending on the treatment that you're on, you can sometimes become pregnant while you're on that treatment and then stop your medication. Some medications are okay in the evidence, not in the guidelines, but in the evidence to continue on for a little while through your pregnancy. And the background around that is we understand that a person who has their disease well controlled in the 12 months before they fall pregnant is going to have less relapse risk during their pregnancy and after their pregnancy. So there's also some background evidence from around these wonderful big databases from around the world, including IMED and MS Base in Australia, that has looked at the natural history of MS and general real world MS experience. And there are babies that are born on treatments, and there are babies that are born on, or maybe not so well planned. And so we have that experience of exposure to some drugs, and that's how we develop evidence around the somewhat safety of staying on medications. But it's not just your regular medications you need to think about. Other medications, maybe symptomatic medications for your MS or other things. So a conversation with your GP or your neuro is really crucial there to working out what you should be on when you're trying to fall pregnant.
And so, where could people get more information about medications and pregnancy?
Yeah, that's a really good question. So I would head straight back to the person who prescribed you medications. I would be encouraging people to have a conversation early on, not when you're about to fall pregnant or after you've fallen pregnant, but planning, if you can, planning a pregnancy, is have that conversation. So you're planning medication stop, or at least having that information to hand about your personal risk.
And even going back a little bit, we're talking about planning pregnancy and having a stable pregnancy for 12 months before hopefully becoming pregnant. Are there things there that people should know or consider about their medications and pregnancy, in those planning stages? Like, if they need to change a treatment, becoming pregnant?
Yeah, so there are many different medications to treat multiple sclerosis. As I said, some of them you could be on while you're becoming pregnant and then come off. Some people will switch across before they get pregnant. So they might be on a medication that isn't particularly conducive to pregnancy. And it's a planning stage where we talk about switching across to something else, stopping the contraceptive pill or whatever contraception they're using, and then falling pregnant that way. We know that about 80% of people in Australia will fall pregnant within the first year. So knowing that there could be a long period of time before you become pregnant, that is a bit of a worry, and we don't know what your personal risk for relapse is or disease progression. So I guess having a plan with your specialist about how long you're going to wait before you get back onto treatment or how long you wait before a referral to a fertility specialist. And they're not going to tell you what you need to do. They're going to work with you in your ideal preferences for planning your family.
Mm. And it's interesting when you say in 12 months, 80% of people will fall pregnant, but that still leaves 20% of people that have difficulty. So, for those people who are struggling to fall pregnant, or maybe they're even towards the end of their 12-month period and thinking, why isn't this happening yet? Like, what are the next steps for people who fall into that group?
Yeah, that's a great question, Jess. So we're saying nowadays that probably 12 months is too long to wait for referral to a fertility specialist. If especially if you're over 35, perhaps closer to 6 months would be of trying should be enough before kickstarting that referral to a fertility specialist. Your GP can provide that referral, and they can also get underway some of the tests that the fertility specialist might need to identify what the issue might be with your not becoming pregnant. That fertility expert will then look at other reasons if they need to and perhaps recommend treatment. And that might be any of the artificial reproductive technologies. There are a lot of them. The most common is IUI and IVF.
Okay. And so for women who do become pregnant using these fertility treatments, are there any sorts of differences between people who fall pregnant, say naturally, versus those pregnancies that are assisted?
There probably are. So we know that MS itself won't affect a pregnancy, although the literature has debated that for a long time. I think it's more cultural in that women who have difficulty getting pregnant are already being more closely monitored. And I think that continues throughout their pregnancy. And there's some concern amongst non MS specialist providers that might be a high risk pregnancy. And so they will, on top of being more closely monitored, they might suggest that the person has a cesarean or alters their delivery plans. I don't think that's absolutely necessary. The more recent literature suggests that a woman having fertility treatment is no different to a woman who didn't need fertility treatment in terms of their pregnancy experience. And if a woman didn't want to have a cesarean, I think that should be supported. And I think the best way to do that is really good communication between the fertility, the obstetrician team, or the midwife network, and the MS care providers.
Absolutely. And so you have an interest in reproductive research. Can you tell us a bit more about the research that's happening in Australia and how this relates to MS?
Yeah. There's some amazing research going on in MS and fertility already. Our colleagues at Monash, particularly Vilja Jokubaitis and Annika Vanderwalt, are heading up some just tremendous studies on big numbers that have really reinforced that the effect of pregnancy on relapse rate and how that is quite protective to be on a medication. And that's really helping us to better understand, to individualise patient care in Australia. It's tremendous. I'm hoping our research is going to add to that knowledge. And I'm very fortunate to be a co-lead of a study in Newcastle, but it is an Australian-wide study looking at the experience of sub and infertility. And my personal interest is in the experience so far. We're also going to be looking at the experience of people who are currently undergoing IVF or having difficulties with falling pregnant. And we don't actually know how many people in Australia are using or have used technologies to help them fall pregnant. So that's the first question we want to answer. But we think there are probably gaps in what the best way to provide care. And we think there are definitely areas that we can improve. So we would like anyone who is currently using fertility technologies or anyone who has in the past to consider enrolling with this study so we can better learn and perhaps come up with some better strategies for managing for people in the future.
Yeah, absolutely. It sounds like an area of research that is really needed given the use of assisted reproductive technology is becoming more prevalent. So where can people find out more information about the study or look at getting enrolled? How would they go about that?
Yeah, Jess. So, for anyone who's interested in sharing their experience of fertility issues or going through fertility problems now, they can find more information on our website. So, if they Google MS Clinic Newcastle, there'll be the link to the study there and they can enroll directly that way.
Amazing. That's really good for people to know. And so, lastly, I guess in all of your experience, being an MS nurse of over 21 years in the clinic seeing people, do you have any sort of pearls of wisdom for women who are thinking about pregnancy or trying to start a family and need support?
Yeah, absolutely. So the first thing I'd say is plan. Start thinking about pregnancy, even in your years where you're not even thinking, where you're trying to actively avoid pregnancy, but start thinking about what you might like to do when. We're putting people on treatments for a long time, and so that treatment plan should include your future baby plans. I'd say don't stress. Stress is not good for MS. Stress is not good for you anyway, irrespective of any disease you might have, but it does also make it difficult to get pregnant. Get healthy. If you're a smoker, cut down or stop. If you can cut down your alcohol intake, that'd be great as well. Plan those medications, and not only your MS medications, any of the other symptomatic medications or other disease medications you might be on. Think about how they interact and where you might need to stop or change those. Think about what you want for your pregnancy and your post baby delivery and restarting medication after that. I think starting that conversation early about all of these things is going to be key to having best outcome. And I'd say go looking for those resources. Talk to your specialist, talk to your MS nurse, talk to your GP. But also MS Plus and MS Australia have some great resources and the literature about the research there for you to read about what's going on in the world, what you should know to get best outcome for you.
Absolutely. That is so helpful. And I think it's really good information because I think as women, there's this cultural idea that you will fall pregnant very quickly. But in reality, that's not the case. So there's actually a lot that goes into planning a family.
Absolutely. That's the Disney version.
Yeah.
And that doesn't happen for everybody. And sometimes it needs a little bit more effort and a little bit more help from outside to get that Disney outcome.
Thank you, Susan, for all of that information, and really interested and excited to hear about the outcomes of your research as well. So thank you so much for speaking with me.
Thanks, Jess, for having me.
For more information on anything we have covered today, please get in touch with MS Plus Connect on free call 1800 042 138 or email connect@msplus.org.au.